I'd ask all participants to mute themselves, please, as you arrive. Welcome to the CSW event, Full and Effective Women as Independent Actors in Fertility Management. My name is Monica Lampton, and I'm a member of the Womb International team here at the UN, and I'm calling in from Vancouver, Canada today. We have a great event planned. We have 4 speakers who will be taking the floor in a few minutes. I just wanted to give you a little bit of an introduction to begin with. For those of you who are calling in on the UN platform, welcome. We also have an overflow room on Zoom, and so welcome to all of you as well. We will be having a question and answer time after the speakers, all 4 speakers have had a chance to present. And those of you who are on this screen through the UN will have a chance to put your questions directly into the Q&A box. If you look down below all of the squares on your Zoom, you'll see chat. And so we'd ask you to click on the chat, and you can put comments in there, and you can also put questions, and we will be monitoring those and moderating a question and answer session at the end. Unfortunately, for those of you in the overflow room, your questions will be answered, but not in real time. And so we invite you to put questions in the chat box on the Zoom link that you have. And then we will respond afterwards to those questions. So there's 2 ways that we can respond. One is we will keep that overflow room open after the event is closed, and we can answer your questions then. We can also set up an email or another time of communication exchange with you. So please do let us know how you would like that to work through the chat box in the overflow room. Those of you who are on the UN platform, you're welcome to join us for the informal chat room. I will be putting the Zoom link into this chat box later on. So everyone is welcome. You'll just need to sign out of this event because it will close automatically on the UN platform, and then sign in again on the link that I will be putting in the chat box, and we'll continue with some informal discussion there. Also, for those of you in the overflow room, if you could please put your name and email address in the chat box, let us know where you're calling in from. We'd really appreciate it. We get a great service from the UN for everybody who's officially on the UN platform. We already have your name and your email through your registration. And so we can follow up with you that way, but we don't have access to that from the people in the overflow room. Our topic today is full and effective women as independent actors in fertility management. When we focus on the idea of independent and autonomous, our minds often go directly to the idea of family planning and also our health, managing our health. And all of our speakers today will focus on that, how in their own practices, they work with women to gain that independence, gain that autonomy, and have a much more positive impact in their overall life. Building on that, once women have independence and autonomy in that way, they can plan better for the future. When you have confidence that you will have good health, when you have confidence that you won't get too many unexpected surprises, when you have confidence that you can plan your family, you can plan effectively for the future. And that means you can make an investment in your own education, in your children's education. You can make an investment by looking for new employment. You can make an investment by moving to a different region, by building different kinds of networks. There's all kinds of wonderful ways that having better autonomy and independence in your fertility management can lead to more autonomy and independence in your whole life and in your family's life. So on that note, I want to say welcome again. We're thrilled to have 4 great speakers with us today, and I'm going to pass it over to our 2 hosts of the afternoon, evening, morning, depending on where you're calling in from, Kristen and Allison. Take it away.
Well, hello, everyone. Thank you so much for being here. My name is Kristen Putnam, and I have been managing my fertility naturally for 15 years. I have been a certified Billings instructor for 11 years, a supervisor for teacher in practicum for about 6 years, and I've served on the BOMA board of directors for also 6 years. And I'm very pleased to be able to be a part of this team at the UN for the last 3 years. I live with my husband and my 8 children in Washington State, just about 5 miles south of Canada. And before you ask, yes, all 8 children of mine were planned. I would like to introduce our first speaker today. Dr. Lek Lim Chan is a doctor of natural medicine in Malaysia. In his practice, he has a special interest in using the Women's Billings Ovulation Method chart as a diagnostic tool. He collaborates with doctors all over the world about hormonal levels and endocrine abnormalities and how they relate to a Billings ovulation method chart. He has given teacher trainings for the Billings method in Malaysia, Singapore, and Brunei. He has taught the method in countries all over the world, including Singapore, Australia, the United States, the United Kingdom, and Thailand. He has continuously served as either the president or the vice president of Natural Fertility Awareness Service of Malaysia since 1997, and he has been an associate director of Womb International since 2013. He's also the education and scientific coordinator for the Billings method in Malaysia. Thank you so much for being here with us today, Dr. Chan.
I'll share screen now. Okay, so as Christine has already introduced, the topic is women, full and effective women as independent actors in fertility management. And just a little introduction, further introduction on my background. I'm running a Natural Family Planning and Fertility Regulation Center. The objective is to promote and teach fertility education through the Billings ovulation method for the purposes of health monitoring and natural fertility regulation. The Billings ovulation method here in Malaysia is also taught as part of marriage preparation, and the follow-up with the patient's own chart is very important. We always do that in ensuring proficiency in observation and charting, and that will then lead on to independence in their fertility management. The schema of my presentation will be Billings ovulation method is a basic knowledge that women should know. Why? Because it will lead to greater autonomy in managing health issues, and also greater autonomy or equality in relationship in marriage. At the end of it, I will present 2 case studies to illustrate some of these points. Now, we know that generally women know only when bleeds come and very little else. Most women don't even know that it is possible that they don't ovulate, although regularly bleeding. And some of these women, of course, wonder why they are not conceiving, assuming that because they have assumed that regular bleeding means fertility. Now, women with irregular bleeds are in a worse situation. Oftentimes, they don't know why, and why they are having these irregular bleeds, and are very frustrated. They are not like other normal women, and all they get is medication to get them to bleed when they don't. Some couples who have no underlying issues may find difficulty conceiving, and all they need is some basic fertility education to be able to recognize the signs and symptoms of fertility and infertility, and therefore to be able to time sexual intercourse within the fertile window. This will not only save time, but money also for expensive investigations or even unnecessary treatments. Once the health issue has been identified through normal abnormal Billings ovulation method charts, women will become conscious of what health factors they need to monitor. For example, vitamin D levels, thyroid hormones, or insulin levels, just to name a few. They then will possess the knowledge of their reproductive health and thus become more independent to be able to know if the condition is maintained or worsening. And by that, I mean by looking at the, if they are continuing with their charting, they will be able to see those things, whether it appears on their charts. For example, is their insulin resistance worsening? Is the level of medication that they are taking adequate to cope with insulin resistance at that time? Now I move on to talking about how this knowledge of natural family planning, particularly in my case is the Billings ovulation method, how it can lead to greater autonomy and equality in a relationship or marriage. Now we know that marriage is meant to be an equal partnership. And the use of natural family planning in a marriage requires the cooperation of both husband and wife, of both partners. The couple is then sharing in each other's life in a very intimate area of their married life. And therefore, the cooperation and the communication will help build up a healthy married life based on mutual respect and sacrifice, compatible with what marriage is all about. Once the wife understands her cycle of fertility and infertility, she comes to realize with awe how beautiful her body is. On the other hand, understanding of the wife's cycle of fertility and infertility, the husband also becomes conscious of how marvelous the body of the wife is created. He then, of course, comes to treat with awe and respect something which he himself doesn't possess. As a result, the couple can together make the decision on how to use this knowledge of the fertility and infertility to regulate it, to plan for a child or to postpone. Now I move on to the examples of two case studies reflecting the benefits of fertility awareness and natural family planning in terms of the women's autonomy and independence. Excuse me. In this first case is a lady who came to see us, came to see me at the age of 31 a few years ago. She had been married for 6 years, hoping to conceive, but was unsuccessful. One gynecologist who did her female hormone tests told her that she would probably reach menopause within 2 years. And that's amazing. I mean, it does happen, but it's very rare. The BMI, her BMI was 17.8 approximately, and her charts, when I look at the charts, the chart shows regular bleeds with some follicular activity, but no peaks. I mean, that's how I read charts as a Billings teacher or instructor. And when we tested, among a few other tests I've just highlighted here, the vitamin D was on the low side. Now, I didn't believe at that time that this vitamin D was that low to cause the infertility. So I told her, this is the only one that we have identified. Let's put you on vitamin D supplementation. And we commenced of course, the D3 or cholecalciferol supplementation. And 3 months later, she presented charts showing peaks. And of course, in this particular chart, there was intercourse around the peak, but there was no excuse me, the pregnancy did not result. But the fertility education had taught her to recognize the signs and symptoms of fertility. 10 months after starting, to cut a long story short, 10 months after starting the vitamin D supplementation, she sent me a message. I used a home pregnancy kit yesterday and it came out positive. Haven't gone to see the doctor yet to confirm the results. Now the chart of conception is here. She mentioned in the message that she had this very slippery day, which she recognized as the most slippery she ever had within the last perhaps 6 months. There was no peak. There was no build up to the peak. But this particular day of very slippery told her that it was a very, the symptom shows that she is very fertile. And so intercourse took place that very evening, and that resulted in the pregnancy. For those who are not familiar with the Billings method, of course, then you would say that would this mean that if she were to postpone pregnancy, then would pregnancy result? The answer is no, if she follows the rules correctly, because she would have abstained right through until the 1, 2, 3 year. And so in that time, she will not be, outside of that time, she will not be able to conceive. The ultrasound scanning that was done a little bit later estimated that the conception date was the 5th of November. And if you look at this chart, how close that is, it's actually the next day to the very slippery. The ability to recognize fertility autonomously resulted in that pregnancy. She was able to recognize it without further consultation. After the pregnancy was confirmed, her vitamin D was checked again, and it was already 96.9, well within the range. And this is a picture of the daughter, 1 year old. She is now, of course, I think about 7. Now, in this case, second case, was a 27-year-old married for 4 years, trying to conceive again unsuccessfully ever since the wedding day. The BMI was 22.5. She is not overly weighty, with heavy weight. She had a history of irregular bleeding. The last full bleed was 9 months before the first consultation. She had some spotting, although she had some spotting a few months before, but no full bleeds. There are also times with continuous bleeds for a few weeks at a time, so menorrhagia. Both the father and mother were diabetic. The typical chart that she showed looks like this, with some follicular activity, and includes, of course, the spotting, a lot of spotting days and some dry days in between. When we did the glucose tolerance test, among other tests, this was the 5-point GTTI. Professor Pila calls it GTTI, glucose tolerance test with insulin thrown in as well. So it's 5 points. So if you look at the glucose test, she was normal. She was having normal fasting glucose at 5.2. But when you load on to the glucose, 75 grams of glucose, you see all these half hour, one, etc., until 2 hours were all in the red. And the 2 hour insulin, 2 hour glucose is almost near 11, which is the limit beyond which is diabetes. Her urine also contains some traces of glucose. And the insulin, if you look at the insulin, the fasting insulin, half-hour insulin was normal, within normal range of what Pilar has said, but the 60 minutes, 90 minutes, and 120 minutes are definitely far beyond. You see, at 2 hours, less than 60 is Pilar's limit, but she is having 404. The rest of the test that we did was okay, except the vitamin D deficiency. And she was, of course, given vitamin D supplementation. She started metformin here on this day, 2 tablets of 500 milligrams. And about 2 weeks later, she had a very wet, clear, stringy day. So the fertility returned very fast, very quick response to metformin. 3 months after starting the two tablets of metformin, she was still having no peaks. And so we increased the metformins to 3 times, 3 tablets per day. And another 2 months later, she got pregnant. And she got pregnant again, like the first case that I showed, without any peaks. It was a very slippery day here, slippery, clear, stringy day. Intercourse happened to take place only the day after, but that resulted in the pregnancy. But she did not check the confirm the pregnancy until 2 months later, because she thought she was having irregular bleeds again. Then she did the gestational diabetes test, and it was found definitely this one is far too high, because during pregnancy is 7.8. She has gestational diabetes. After that, she continued on, and she took 1 tablet of metformin before each of the main meals, breakfast, lunch, and dinner. And you can see here that all the readings were within normal range. She did 3 times. I just pick up three of them. The baby was born 2016. In fact, I received the news in Hong Kong after I arrived from a speaking tour of the US. This baby had defecated in the uterus, and there was suspected infection. There was fast breathing, but eventually she recovered. And the second baby was conceived. I'm coming to the end now. Second baby was conceived on metformin in May 2019 autonomously. So after being helped to get back her regular menstrual bleeds, she knew how to monitor to ensure that she has regular ovulations, which of course we know is a sign of health. Therefore, she was able to manage her own fertility independently. And here in this photo, you can see the two beautiful children that she and her husband have. Thank you very much. That's all for my presentation.
Thank you so much, Dr. Chan, for that excellent information on using Billings as a diagnostic tool. It is such a beautiful gift to women's health. So next, we're going to hear from Dr. Mary Martin. Dr. Mary Martin was board certified by the American Board of Obstetricians and Gynecologists in 1997, with special interest in fertility and natural family planning. She was elected to fellowship in the American College of Obstetricians and Gynecologists in 1999, and now practices in Oklahoma, Texas, and provides a telemed option as well. She received her Doctor of Medicine degree in 1991 at the University of Illinois College of Medicine. She completed her combined internship and residency in obstetrics and gynecology at the Carline Center for Women and Children at Roanoke Community Hospital in 1995. She's an ambulatory active member of St. Anthony Hospital staff and is an attending physician for the Family Medicine Residency Program. She was trained in the Billings ovulation method in Australia, of which she often says that despite her extensive medical education, she did not truly learn gynecology until she was instructed in the Billings ovulation method. In the United States, Dr. Martin established the first ever application of Billings method research in a clinical setting. She has served on the board of the official womb affiliate in the United States, BOMA USA, and was named a specialist consultant to Womb International. Thank you so much for joining us today, Dr. Martin. I believe that you're muted. There you go.
Thank you very much, Kristen. And regards to my wonderful colleague, Dr. Leklim Chen. He always does a wonderful job statistically. I'm very practical, however, and so between seeing patients by telemedicine and flying back and forth to Texas every other week, I happen to be in clinic today and with my door firmly closed. And although they have tried not to have patients waiting for me, I'm afraid I do have at least one waiting for me. So I'm going to start and tell you some practical things. I'm glad, Kristen, that you spoke my favorite line, that although I was trained in the United States with a very good community program. And what do I mean about a community program? It was in Roanoke, Virginia, where we actually were the only obstetrics and gynecology residents in Roanoke. And as part of our training, we rotated to the University of Virginia, which is a very fine academic program. But anyone who has been to Roanoke or UVA knows that the Roanoke residents got a very superior practical training in that we were the only providers. And the trouble with training in obstetrics and gynecology in the United States is that the patients tend to be primarily Medicaid, in other words, uninsured except for the government programs. And so they're young, and we do primarily obstetrics and gynecology. However, in Roanoke, the advantage was that as we were the only residents in town, the private attending doctors who had trained at various wonderful places welcomed us to come and participate, certainly with surgery and the management of their patients. But I can tell you, despite that, still, and although I had excellent training, I truly did not understand gynecology to the extent that I did after sitting through listening to two senior teachers from Australia who had themselves participated in the urinary hormone assays, which were started in the 1950s by Professor Jim Brown. And this is the advantage of having lived as long as I have. I had the distinct pleasure and honor of working with both Professor James Boyer Brown and Dr. Eric Odeblad. My colleague is Dr. Pilar Vigil, whom Dr. Chan mentioned several times. Pilar and I, as it turns out, are very close in age. And although she has outperformed me when it comes to, she has a PhD in human reproduction, as well as my credentials as a fellow of the American College of Obstetricians and Gynecologists. Pilar has founded FEM, which is Fertility Education Medical Management, the Reproductive Health Research Institute in Santiago, Chile. And I've been there and collaborated. So I've been very honored and very fortunate to have been trained by the people who actually did the research with the Billings ovulation method. And that was primarily Doctors Brown and Odeblad and others as well, certainly collaborated, including the doctors Billings themselves. But at the time, they were also running busy practices, as we do. So I'm very, very delighted still to be collaborating with Professor Vigil, who has taken the research, the historical research of the Billings ovulation method and formed and designed diagnostic and treatment protocols, which now comprise FEM, which is Fertility Education and Medical Management. Where does all this go? Well, like Professor Chan, I have patients every day who conceive. We consider infertility not 12 months of trying to conceive, as my reproductive endocrinology colleagues say, But if you have 3 fertile cycles and fail to conceive, then there's an underlying problem. Secondly, if you have 2 irregular cycles in a row or 3 in a calendar year, that this patient needs a workup. So these are 2 things already that set us apart from our colleagues. Today I've done mostly gynecology, and what I wanted to tell you is just today I saw a patient who is in her late 40s. She is 48 or 49. She has not had a menstrual bleed in the past year, but divulged to my nurse practitioner student and me that she'd had a pregnancy termination. She became very tearful about that. And recently, her youngest sister, who was only 41 at the time, or 43, I forget which, was diagnosed with breast cancer. Now, why is this significant? Well, certainly, in talking to this patient about her own history, her menstrual history, and her inability to conceive after that voluntary pregnancy termination when she was in her late teens or 20s, she's thinking that, well, you know, that's the punishment I get for having terminated that pregnancy. But her menstrual history and now her GYN history suggests that it's not only her sister who is at risk of developing breast cancer, as there's no other family history of breast or ovarian cancer. And so in talking to this patient, not only her GYN history, her irregular cycles, her history of insulin resistance and so forth, tells me that it's not just the sister that I need to look at. And in fact, this patient, because her sister was diagnosed, fortunately, or I say unfortunately for the sister, but fortunately for this patient, is that she is a candidate for genetic testing. Ordinarily, you can't have genetic testing unless you have 2 first-degree relatives who have breast cancer. But because the sister was premenopausal when she was diagnosed, and of course I asked, do you suppose your sister took oral contraceptive pills or had a pregnancy termination? And she said, well, just like me, I've never admitted it to anyone but you today. But she said that may have been the case. So knowing about your obstetrical history and gynecologic history, by doing the charting and asking the right questions, we're able to point to specific risks that this patient certainly would need to look at. Now, why know if you're a carrier? Well, because if there's more than a 20% lifetime chance of developing breast cancer, then simply doing a mammogram once a year is not enough. We do quarterly surveillance. So in this patient's case, if she has more than 20% lifetime risk of breast cancer, then just doing a mammogram, 3 months after that, we would do a clinical breast exam. At the 6-month mark, we would do an MRI, which actually shows us where the tumor is. At 9 months, another clinical breast exam. In the United States, it's well known that the actress Angelina Jolie's mother had ovarian cancer. And it's been well reported that Angelina had a subcutaneous mastectomy. In other words, they removed the breast tissue and reconstructed the breasts, and that she had her ovaries and uterus removed as a result of that. So not only is using the charting and the history that we have learned from the Billings ovulation method valuable in family planning and preventing pregnancies until one is ready for one, but it also is important later in life when we're looking at risk factors. Gosh, I feel like I've said a mouthful already. And I know that we were running a little bit behind. So if anyone has questions, I would be very happy to answer those, but I actually have a patient waiting at the moment. So if there are no objections, I thank you with all my heart to have this opportunity. This is actually the second time that I've had the opportunity to address this forum. The last time was actually in person in 2015. And I know that the speakers who follow me, who preceded me and will follow me, will have a wealth of information to give you as well. So I thank you very much for listening today, and I'm available for further questions. If I'm still with a patient, I'm sorry, but I certainly will try to get back to people. Thanks so much, Kristen.
Thank you so much, Dr. Martin, for being here in between patients to share your story and your expertise with us.
Bye.
Bye. All right, well, I'm going to go ahead and turn the event now over to my colleague, Allison Dreher.
Hi, thank you, Kristen. My name is Allison Dreher, and I've been a Billings Ovulation Method instructor since 2013. I've been a member of the Womb International NGO since 2015. I'm also very passionate about women's healthcare and integrating the science of the Billings Ovulation Method when treating women's health issues. I truly believe that this information is something that every woman has a right to know. And so without further ado, let me go ahead and introduce our next panelist, who is Dr. Marguerite Duane. Dr. Duane is a board-certified physician in family medicine. She attended medical school at the State University of New York at Stony Brook, where she received her MD degree with recognition in primary care and completed her family medicine residency at Lancaster General Hospital in Lancaster, Pennsylvania. Dr. Duane has experience caring for men, women, and children at every stage of life. She is an adjunct associate professor at Georgetown University, joining the faculty in 2004, and continues to mentor students in research part-time. She is also the co-founder and executive director of FACS, the Fertility Appreciation Collaborative to Teach the Science, a group of doctors and medical professionals dedicated to educating healthcare colleagues about fertility awareness-based methods. Additionally, she is trained as a Creighton Medal consultant and a Teen Star educator. Previously, Dr. Duane served as medical director of 2 community health centers in Washington, D.C., where she cared for an almost exclusively uninsured population. Dr. Duane enjoys spending time with her husband and fellow family physician, Dr. Kenny Lynn, and their 4 beautiful children, Isaac, Eden, Ellis, and Gianna. Welcome, Dr. Duane.
Thank you so much for having me. I am delighted to be here to speak about a topic that is very near and dear to my heart, and that is educating and empowering women with the knowledge of the way their body is designed to function. So I would like to go ahead and share my screen. I'll talk a little bit from my slides, but I'm also going to talk a little bit from my clinical experience in caring for patients of all ages, men, women, and children. So again, I am the co-founder and executive director of FACS, and our mission is to educate our healthcare colleagues, our physicians and nurse practitioners, midwives and PAs, pharmacy students, anyone who provides healthcare. Because unfortunately, the healthcare community are probably the least knowledgeable about modern natural methods of family planning and fertility awareness. So through FACS, we try to educate them through our conferences and our elective, and we'll share more information about that. But let me start with what matters. And this is the signs of the female cycle. I'll talk about how these signs educate women and allow them to monitor their cycle and use it as a 5th vital sign to understand what's happening with their bodies. Are they healthy? Are they not? What could be the possible underlying issues? And ideally help them connect with physicians that can learn to interpret their charts. I'll talk a little bit about how FABMs or natural family planning can be used for family planning. In fact, natural methods of family planning or fertility awareness-based methods are the only true forms of family planning, because couples can use this information if they are trying to achieve a pregnancy, and they can use this information if for whatever reason they need to space or postpone a pregnancy. And finally, I'll talk about the benefits of using these methods. So what are natural methods of family planning or fertility awareness-based methods? We use the terms interchangeably. They really highlight that women can use daily observations of specific physical signs or biomarkers to identify the potential days when they may be fertile. Fertility awareness-based methods highlight how women can use them to track and monitor their reproductive health. The term natural family planning really highlights that these are based on natural signs. Women do not need to use any drugs or devices to suppress their fertility, but rather through educating themselves and becoming empowered with knowledge about the way their body is designed to work and cooperating with their partner and modifying their behavior, they can use it from a family planning perspective. So again, at Facts, we are committed to educating women to know your body. When you can track your cycle and the signs of your cycle, this information empowers you to understand where you are, what's happening hormonally, and how you can use this information, again, to monitor your health and plan for your family. What are these signs or biomarkers? Well, there are three main signs that all reflect internal hormonal changes. So these external signs that a woman can observe actually reflect the internal hormonal changes a woman experiences. The Billings ovulation method teaches women to observe cervical secretions. What's unique about Billings is they really teach women to focus on the sensation, what they feel throughout the day. In this way, even the Billings ovulation method can be used by a blind woman. So she may not be able to see the mucus, but she can still observe by paying attention to sensation. Other methods may incorporate the use of basal body temperature to confirm whether or not ovulation has occurred, and still other methods may use urinary hormone measurements. But what I like most about the Billings method, and I should say I am trained as a Teen Star educator, which integrates the Billings method teachings, is that it's focused on the very simple sign that every method integrates, and that's the sign of cervical fluid secretions. And what those external signs actually reflect is this intricate orchestration of the female hormones that happens every day. How the brain communicates to the pituitary, that communicates to the ovaries, to allow this intricate interplay of hormones that women, through observing these simple signs, can better understand what's happening on a day-to-day basis with their hormones. How can they track it? Through using a chart. So this is an example of a chart where women learn to track their menses, their dry days, their cervical mucus days. And what these simple stickers on a chart actually reflect, again, is the intricate interplay of the hormonal changes that the woman is experiencing. So every woman, whether or not she has a college degree or a fifth grade education, whether she lives in a mansion or may live in rural India, can learn to observe external signs such as cervical mucus to understand the unique, intricate hormonal changes that are happening in her body every single day. It's absolutely fascinating. The other thing that's important to note is that women can learn to do this starting at a very young age, even as they go through puberty. Young girls can learn to make these observations, to be empowered with knowing when their next period may arrive, to know that that cervical fluid that they see, that discharge, doesn't necessarily reflect a disease, but may actually reflect the normal rise in her estradiol levels. I share the story sometimes. I had a young girl who came in to see me at my community health center in Washington, D.C., where we served, a fairly low socioeconomic population. And this 15-year-old girl was brought in by her mother, who was very concerned about the fact that she was noticing all of this discharge on her daughter's underwear. And she was concerned that perhaps her daughter had become sexually active. Maybe she had a sexually transmitted infection. And the young girl had promised her mother, I swear, Mom, I'm not with anybody. I haven't had sex with anybody. I don't know why I have this discharge. I just get it. And as I tried to calm the mom down and talk the daughter through her cycle, she described she would get her period for a few days, and then she would notice nothing. And then for a few days, she would notice this discharge. And she swore, I make sure to shower every day. When I have swim team practice, I take off my wet bathing suit so it doesn't cause any irritation. But every month I seem to get this discharge. What she was describing was her normal cervical fluid secretions, which is produced under the influence of the estradiol. When I explained this to the mother and the mother was shocked. She's like, but I've never noticed that. Why don't I see these changes? How is it that my daughter has this and I never have? Well, I then asked the mother, have you used hormonal birth control? Hormonal birth control is actually designed to suppress the normal hormones that a woman makes on a daily basis. And the mother was like, well, of course, I've used hormonal birth control since I was a teenager. And I explained to her the act of using hormonal birth control suppressed the normal signs. So that's why she may not have noticed the discharge. But in fact, this 15-year-old had identified the normal cervical fluid secretions that was a result of the estradiol changes. Having that knowledge empowered this girl so she no longer felt afraid or scared or dirty or that there was something wrong with her. She knew that it was a sign that her body was functioning normally. And when she learned to track the cervical fluid phase and calculate the time between the end of the cervical fluid phase and the next period, she became well equipped at identifying when her next period would arrive. So she was never surprised by her monthly visitor. So again, these regular changes in hormones are actually detected or can be detected by these signs that young girls and women can learn to observe and chart. Again, when women learn to chart their cycle, this can serve as a fifth vital sign. Just like individuals can track their respiratory rate, their heart rate, their temperature, and their blood pressure, women can learn to chart the signs of their fertility. And just as an abnormal blood pressure might suggest something is wrong, if a person has an elevated temperature, that might suggest an infection. If women observe abnormalities in their chart, this can actually be an indication of something wrong. At FACS, we actually teach medical school students to learn how to read the chart of the female cycle, just like they learn to read an EKG. So for the medical professionals in the audience, you know, when you look at an electrocardiogram or an EKG, you look first at the rate and the rhythm and the axis and the pure interval and the QRS complex. We go through it in a systematic fashion. When we learn to read the chart of the female cycle, and I'm just going to go back here, when we learn to read the chart, we learn to look at the overall cycle length, the menstrual cycle length, the cervical fluid cycle length, and the luteal phase length and follicular phase length. When we detect abnormalities, women can say or be able to detect that they may be at risk for other conditions. So again, the female cycle chart can serve as the fifth vital sign. And even the American College of Obstetricians and Gynecologists recommend that including an evaluation of the menstrual cycle as an additional vital sign reinforces its importance in assessing the overall health of women. Fertility awareness-based methods can also be used by family planning. For family planning, again, these are the only true methods of family planning. How do these work? Well, women are actually only fertile for a very short time in the cycle. Healthy men, on the other hand, are almost always fertile when they're able to produce when men are able to produce sperm on a daily basis, they are fertile all the time. But women are actually only fertile for a very short period of time. And when they learn to chart their cycle, they can identify that window of fertility, and couples can plan to avoid sexual relationships if their goal is to prevent pregnancy, or they can target that time. Natural methods of fertility awareness-based methods can be used very effectively to avoid pregnancy, comparable with commonly used synthetic hormones, which has a whole host of effects. This is a chart of another patient of mine. As you can see, she had somewhat longer than normal cycles, but she very much wanted to get pregnant. Most doctors might tell women, well, you should have sex around day 14 because they think that the cycle is 28 days in length, and so women ovulate on day 14. Well, as you can see, this woman's cervical fluid phase oftentimes didn't even begin until the third week of her cycle because she had much longer cycles. By charting, I was able to guide her when to have sexual relations. And as you can see here, she actually conceived in this cycle here. Now, you may look at it, she clearly did not conceive on day 14. She had no fertile cervical fluid. In this cycle, she actually conceived on day 27 of her cycle. Why was charting so important for this woman? It actually helped us to more accurately date her pregnancy. Based on her last menstrual period, she was originally given a due date of April 24th. But when we calculated the due date based on when she conceived, her due date was much later, on May 6th. And this actually allowed for much better, more effective management at the end of her pregnancy. There's that little baby boy there, who was actually born even a week after his due date. So there are many benefits to fertility awareness-based methods. These are a healthy alternative to conventional forms of birth control that actually suppress the cycle and have a whole host of side effects. In fact, the World Health Organization recognizes modern fertility awareness-based methods as the only form of family planning with no medical side effects. I'm going to skip ahead because I'm running out of time, but here's just a list of many of the side effects of birth control pills and hormonal birth control. As you can see, it affects every aspect of the female body. But when women learn to chart their cycle, it does not interfere with their normal function in any way, shape, or form. Fertility awareness-based methods can also be used to address a range of women's health issues, as my colleague Dr. Chuck and Dr. Martin both informed. We can use these to address polycystic ovarian syndrome and PMS symptoms, painful and irregular periods, postpartum depression, and infertility. Fertility awareness-based methods combined with restorative reproductive approaches are very powerful tools to more effectively target and restore women's reproductive health to normal. The multitude of benefits of natural family planning not only extend to the woman's health, but to the couple's relationships. Couples report improved communication, shared responsibility. The idea of having a baby is no longer solely the burden of the woman or the responsibility of the woman, but they recognize it as a shared responsibility. This shared responsibility can often engender mutual respect because they recognize the important role that both the man and woman play, both in helping to achieve pregnancy as well as prevent pregnancy. Studies show that couples that use natural family planning have much lower divorce rates. And there was a large study of more than 2,000 couples that showed 2/3 actually reported improvement in their sex life and relationships with the use of natural methods. So for more information, Facts does provide a medical update. We have an article that cites the effectiveness of the methods based on the highest quality research studies to date, and these are all available on our website. We always recommend learning from a trained instructor, just like I'm not going to have my 16-year-old son learn how to drive by reading a book or using an app. We always recommend learning from a trained instructor. And if you'd like to learn more about the medical or health applications of using fertility awareness-based methods, we invite you to join us at our upcoming virtual conference on May 14th and 15th. We're delighted to have Allison Dreher, who's our host today. She will be presenting specifically about using fertility awareness-based methods in the adolescent population. So I know we're short on time. I'm happy to take questions during the Q&A session. And I want to thank you all for being here and for helping us share the facts about fertility so we in turn can educate and empower women and engage men once again in family planning and reproductive health. Thank you very much.
Thank you so much, Dr. Duane. It is refreshing to hear doctors recognizing and implementing the science of fertility awareness-based methods in their practices. I thank you for that wonderful presentation. I truly do see and believe that FABMs should be included in the best practices when we are treating women's health issues. Our final panelist comes to us all the way from Guatemala. Dr. Flor de Maria Ortega received her medical degree from Francisco Marroquin University in Guatemala City in 2006. She completed her residency at University Hospital Esperanza in 2012. She has treated patients in many settings, including a family clinic specializing in HIV/AIDS and with Doctors Without Borders in France. Her personal experience of having overcome infertility using fertility awareness-based methods for family planning, and also the discovery of the advances of reproductive medicine through telemedicine, has given her a deep desire to make this information available to all women and their partners. She co-founded Fertilidad de Integral in 2019, a telemedicine clinic specializing in women's health. Dr. Ortega utilizes FABMs to diagnose and treat underlying hormonal issues, as well as helping her patients plan their families naturally. Dr. Ortega finds that fertility awareness-based methods empower women both personally and in their relationships. Welcome, Dr. Ortega.
Thank you very much, Allison. Well, good afternoon, everybody, and greetings from Guatemala. I am very grateful and honored to be forming part of this panel of professionals who have been leading the way into a healthier future for women and also towards a real empowerment for women. As Allison mentioned, well, my story with FABMs began in 2014 after 3 years of struggling to have a baby. Finally, I found an FABM and was training it. And eventually, well, I got intervened and 9 months after that, I was pregnant with my first son. I am a mother of 2 little boys, and I am married. And well, we are very happy with these 2 boys. And well, my history with FABMs is quite long since then and a little bit complicated. I have had identified many issues related to this, especially not only the physical, but also I have identified that this was affecting my mental health as well. And eventually, well, I got the appropriate treatment for this, not the antidepressants, not the anxiety medications, but I started getting hormones, the appropriate hormones in the appropriate doses. So I was able to cope with this as well. Today I want to share with you one of my patients' experiences. This is a very short story, okay? And well, I would like to let you know that in Guatemala, we are around 17.1 million persons, okay? And 59.9% of these persons are below the level of poverty. 29.8% of the population is under extreme poverty. So that is just to give you an idea of how our country is. This person, I'm gonna change her name, Rosie. She's a 19-year-old woman who arrived from an underserved area in the beach area of the country. And she
¿Puedes pedir?
Okay. So she arrived from this place to the capital city just 2 months ago in January. And less than a week after her arrival, she started having her menstrual bleed. This bleed was so excessive that she was debilitated. And she actually was considering going back home and quitting her job. However, she came to help here an elderly couple who lives alone, and by that time, the daughter of the couple was here, and she asked her what was going on and offered help. So they contacted me, and I paid her a visit. I could see by her clinical features, it was very evident that she was overweight. Actually, she was obese, and she had this darkened skin all around her neck. So I just started thinking about insulin resistance when I saw her. She told me that her last menses had occurred 5 months before, and that every single time this was a debilitating episode. She was even have been told that she had anemia. Former doctors in her community had advised her and prescribed her, and once they prescribed her hormonal contraception at age 15. She took it for 1 month, then she quit it because somebody told her that was bad for her health. Another one told her she had to undergo ovarian surgery because she had cysts. Luckily, the family had no way to pay for the surgery, so she did not have the surgery. And she was also told that she was not going to be able to become pregnant. So there was this lady, very young, with a life project that wasn't very helpful, and thinking about quitting her first job, her first formal job, and well, she was kind of sad, you know. So I asked about family history. There was diabetes, there was soft fertility, there was insulin resistance all over, and they didn't know all of this was related, right? So I started teaching her right away. She learned about the ovulatory and menstrual cycles. She learned about biomarkers, just like Dr. Dwayne explained them, right? She learned to identify them. She learned the qualities. She learned about quantities. She also learned about the meaning of her menstrual features and of her clinical and family history features. And that all made sense in her mind. So after all of this, I asked her if she was keeping up with me, and she really grasped the concept about this being a two-way interaction, about hormones from her ovulatory cycle playing a role in her general health and how her general health was affecting her fertility as well. After this she asked me to help her. And well, we just had to make a decision. Shall we start intervening like in a medical fashion, or shall we start charting? So we said, okay, we'll start both. And why is that? That's why I told you about poverty in Guatemala, because this young woman comes from an underserved place, and well, she was able to finish middle school. Yes, that's a great achievement in Guatemala, but she really didn't have the money to perform laboratory testing. So even if she worked there for 6 months, perhaps she would have some savings for that, but that's really expensive in my country. So we decided, okay, we will start intervening in the most easy way, right? And well, she agreed to it. I told her that perhaps she could have polycystic ovarian disease and that definitely she had insulin resistance. And she started taking this medication. We started metformin, we started vitamin D, and she was very eager to pay for this, not like to pay for laboratory testing, but to pay for the medication. After 1 week of treatment, she was already feeling better. And that was amazing because she reported it to me. But then I paid her a new visit after 6 weeks. What my surprise was that she was losing weight, her waistline has shrinked, she was exercising, she didn't have any more carbohydrate cravings, her acanthosis was becoming lighter, and she did report some moistness, but no cervical mucus. So she was pretty conscious of her body, not like before. And the most evident improvement was that menses arrived 6 weeks later, not 5 months later like before. Now, this time it was shortened and it was not debilitating. The volume, the quantity of days, and all the characteristics of this menstrual flow were a lot better, and she was feeling better. So there comes the funny part, because I asked her, okay, so can you show me your chart, please? And you will see what she showed me. She showed me this. And I was startled by that, but I was grateful that it was, when I asked her, this was via WhatsApp Messenger. So then I just said, well, you know what? I don't know what you couldn't chart, because you had the chart papers that I had printed for her, and you bought your own color crayons. And she was so ashamed, and she was telling me, I couldn't understand you. I thought I understood you, but I was unable to chart on my own. So I just asked her, do you have a smartphone? And that's really interesting fact, because in Guatemala, many people have a smartphone. It's very well merchandised here. So she did have one, and she was able to download the FABM method application, and she started using it right away. And it was really nice to see how, after watching that lady feel embarrassed about not being able to chart properly, then she was charting like she knew everything that was around this. So what happened to her? She was empowered, right? She was empowered because it was a different methodology. And that is something that I will like to pinpoint in this story, that, well, not all of our patients are equal, and we have to be flexible, and we have to give them what they really need. So after this, this young lady has been charting properly via the application. And of course, I'm instructing her more about the qualities and about biomarkers and about what she has to be looking to. And but the real thing here is that she was interviewed just this weekend, and she told me this. She told me, I feel more active and energized. My attitude has improved. And I was wondering what kind of attitude, but it was her general attitude, right? Her overall attitude towards life. And she said, I am glad I was able to keep my job. I just want to get healed. So I am definitely very pleased to see how in such a short time and with such a low budget, this young woman has been able to get empowered in so many areas. I can mention just these few to say. She's managing health issues. She is managing self-education and developing problem-solving skills. She has overridden a handicap she had. She is acquiring body literacy, job, and she is gaining economic autonomy, and she is developing a new life project, which involves health and fertility management as well. So that's what I wanted to share with you today. I know I still have some time, but I don't want to abuse of it. So if you have any questions, I would be very pleased to talk about it. And as I said before, well, this all started with my own experience dealing with infertility, which led me to find these FABMs, but not through medical knowledge, as Dr. Martin mentioned properly. I found it in another place, and it was so amazing to find it and so amazing to be able to take care and take charge of my own self and to be able to manage my medical problems, but also to co-manage my pregnancies. And now I'm, well, trying to keep up with the perimenopausal stage. Thank you very much.
Thank you so much, Dr. Ortega, for your expertise and your personal experience. I'm so glad that you found FABMs, and they're so needed. And the women of Guatemala are lucky that you are there to share the information with them. So at this point, I'm going to pass it back to Kristen Putnam, who is going to moderate our questions. So anyone who has questions, please type them in the chat box, and you can direct them to a specific doctor or just a general question, and we'll get right on answering those questions.
All right, thank you, Allison. Yes, as she said, please feel free to put your questions in the chat. And I am actually going to go ahead and pass it over to Monica Lambton to get us started.
Thanks, Kristen. So there's been a big discussion in the chat about education of young people. And Dr. Duane, you spoke about that in your presentation when you referred to Teen Star. And I was wondering if you could speak a little bit about some of the things that you were talking about in the chat, as well as maybe expanding on that. I was thinking about the story that you told in your presentation about the young girl who and her mother who were concerned that, you know, this discharge was a sign of illness or something bad. I've also seen the flip side of that, where young girls feel extraordinarily empowered by learning about how amazing their bodies are. So I don't know if you have a story like that for us, or if you can just talk generally about how you're involved with educating, or how others can be involved with educating young women about their fertility facts.
Sure, absolutely. You know, as a family physician, I care for patients of all ages. So, you know, before birth and all the way through the end of life. And I think it's really important with young people, we start using correct language at a very young age, like long before puberty, right? We talk to young girls and young boys about their different body parts, and we use correct language. Sometimes it can be a little awkward, especially as young girls begin to go through puberty, to talk about things like menstrual bleeding and cervical fluid or cervical mucus. So it's not unusual. Like, I will try to use words that are comfortable for them and that they can very easily relate to. So I did not include this slide in my presentation, but I often include a slide in the presentation that relates the phases of the female cycle to the seasons of the year. Now, that works if you actually have seasons, but if you live near the equator or very far north, and, you know, winter is one long season or summer is one long season, it's a little harder. But for me, I'll talk about how in the beginning of the cycle, after a woman's period, She'll note dryness, and her basal body temperature, if she were checking her temperature, would be lower. And that's like it is in the wintertime, when the ground is dry and the temperature is colder. And then as we move into springtime, it's March, we're getting ready to move into spring here in the northern hemisphere, the rains start to come and it makes the ground very moist and fertile for planting. And then once they go through ovulation, they'll have a rise in their basal body temperature, and it creates a very warm environment, for growth if there's a new embryo. But then if a woman is not pregnant, she'll shed the lining of her uterus, just like the leaves will be shed from the trees in the fall. So I'll try to use analogies like that to help them understand that, as a woman goes through her cycle and she experiences hormonal changes, she is hormonal, but it's normal, right? If we don't have these normal changes, just like if we don't have the normal seasons, it's hard for our society to grow the food that we need and whatnot. But when it comes to talking with teenage girls, again, I am trained as a Teen Star educator, as I know Allison is as well. And Allison has also developed other program and curricula for young girls. I try to use language that's very simple for them. So we talk about their menstrual bleed as their red flow, and they can learn to identify their red flow, and that's actually a sign of health. If they have a normal, healthy period, it's an indication that ovulation has occurred. And that, after a few days of dryness, they may notice a white flow. And this may be that those cervical fluid secretions or mucus that's clear or white or cloudy. And we refer to that as their white flow. And we teach them very simply to track this and to identify, where they are in their cycle, so they understand at different phases, their energy level may be different, the days before their period is coming, perhaps they'll experience a mild headache or, just more fatigue, and they may feel more tired, and we encourage them to take care of themselves and to nurture themselves. So I think when we teach young girls at a very young age, as soon as they go through puberty, that this can really be very empowering to them. In fact, I remember when I first did one of my early trainings to become a medical consultant, my teacher had talked about, she's always talking about cervical mucus and checking cervical mucus. And her 11-year-old daughter was like, "Mommy, what is cervical mucus? How can I check my cervical mucus?" And this mother, even though she'd been teaching for years, was like, "Well, you don't have any yet." She's like, "But I want to look." And so she explained, like, every time you go to the bathroom, just wait. And if you notice mucus, then you write it down. And one day this little girl noticed mucus and she was so excited. And so she started tracking it. And she literally was able to predict her first period. She saw, initially she had just very scant mucus, but one week she said, "Mommy, I've had it for 4 days now." And her mom was like, "Well, it may be your body is like ready to take that next step." And 2 weeks later, when she got her period, she just felt on top of the world. She could predict it coming because she understood the changes that were happening in her body. We can absolutely educate and empower young girls to do this. It takes time. It takes parents that know and mothers that are willing to share this information. And it takes teachers of these methods that are willing to go out there and share this information.
Thank you, Dr. Duane, for that insight.
You're welcome.
Okay, there has been a question asked about if there is an effort among medical professionals or elsewhere to come together and all use one method. For example, Billings, Creighton, and FEM all use slightly different charts. And thank you for your presentations, she said as well. I feel like this one may be directed at Dr. Duane as well, because you do work with facts, or perhaps Dr. Ortega, there may be some insight that you have as well.
Well, I'll take it first, but I guess Dr. Duane will finish it. So in Guatemala, there is a small group of FABM instructors that is currently collaborating, trying to make a collaboration group and to unite to use the different methods, or to be able to chart in different ways, but to collaborate with patients. That's our initial effort. And but there are a lot of methods, right? So I think it should be tailored to every single user. Dr. Duane?
Sure, I'm happy to add. First of all, among medical professionals, most medical professionals don't even know about most of the methods. Most medical professionals still think the only method that exists is the rhythm method. So we spend a lot of time explaining that, the rhythm method, when it was developed in the 1920s and 30s nearly a century ago was a major advance, but since then, modern methods have been developed, starting with the Billings ovulation method, upon which almost all of the modern evidence-based methods have built their methods. I truly believe, and this is what we teach through FACS, that the best fertility awareness-based method or natural method that is out there is the one that works best for the woman or couple. And that will vary from woman to woman, and that will actually vary for a given woman depending on where she is in her reproductive life. Some methods may be easier. Like, I'm a big believer for the adolescent population, all we need to do is teach them about their cervical secretions. And I think the Billings method does the best way to teach that to adolescents. But as we get, as women get older, we have different needs. Just like there's not one perfect blood pressure medication for all people with high blood pressure, there isn't necessarily one best method. And I talked about how we teach medical students how to read the female chart like they read an EKG, except I then caution them, every EKG is going to look the same, whether you do an EKG in New York or London or Egypt. EKGs pretty much all look the same, but the charts are going to look a little different, but they all contain very similar information. And if as a medical professional, you do not understand what the chart is saying, I always encourage them to ask the patient, ask the woman. She is the master of knowledge of her own body, and she will understand the signs, and trust her to tell you and work with her. As a physician, I strongly believe we need to partner with our patients and not act in a patriarchal manner, dictating to them what they must do, but rather learn from them and work with them to help them achieve optimal health. So no, Nicole, there is not an effort, and nor do I think that there should be, because again, just as though there's not one antibiotic for whatever infection you have, every woman is different and unique, and every couple is unique, and there are different methods for different reasons, and hopefully it will allow everybody to find a natural or fertility awareness-based method that they can work with depending on where they are at that point in their life.
Thank you, both of you. All right, I'm going to direct this question to Dr. Chan. There is one asking, can a woman having irregular periods try taking vitamin D in general?
Thank you. From my experience, low vitamin D doesn't lead to irregular bleeds. So if there is irregular bleeds, it usually means there's something more than that. What I've noticed is for those who are low in vitamin D, they have regular bleeds, but they don't ovulate. So therefore, as far as the Billings chart is concerned, there's no peak. There might be follicular developments, up to perhaps wet, but never reaching slippery. So that's my experience. So if there's irregular bleeds, I think something more needs to be, more investigations need to be done.
And a follow-up question to that, how often should vitamin D levels be monitored in women with this deficiency?
To me, the question, Christine?
Yes, please, Dr. Chen.
Okay. What I normally do, because I've done quite a lot of trials with vitamin D and, dosage and how fast they will catch up to the correct level. My experience has shown that other things being equal, that means there's no extra direct sun exposure, etc., and same sort of working schedule. It takes 4,000 international units of vitamin D3 over about 6 months to get the serum levels up about 40 nanomoles per liter. So what I normally do is I will tell them certain dose. I'll work out the dosage that is required to bring them up to about 80 nanomoles per liter, which is the normal level, and then retest it then. And then we will adjust the vitamin D after that. And I would suggest very strongly that perhaps they should do it at least every year to check on the levels. I think in temperate regions is even worse. Because the vitamin D from natural sources, from sunlight, varies from winter to summer.
Thank you so much for that. Okay, Dr. Martin, I see you're back with us for a moment. I'm going to direct one question to you. There's a question about any advice for engaging medical professionals, or I would also add to that, talking to your own doctor about charting and what you're doing and how to broach that subject.
You know, I think you have to be persistent. A doctor who is not open to this is probably going to be more difficult in other ways to work with. And so I would suggest that you find someone who's really open and supportive of the charting and the beliefs that you have. It's hard. I mean, I've various times in my life, my colleagues, when I start talking about, why I don't prescribe birth control pills, because I actually want to know why a woman has irregular cycles or has developed endometriosis or has recurrent pregnancy loss. I'll give an example. I have many, many patients, and remember, I see the ones that are having problems. The ones that are already self-selected because they're having problems, they're seeing a specialist, and that's what I do. My record is I had a woman who'd had 11 pregnancy losses. I have many that have had 7 to 9 losses. And so my advice is simply just keep looking until you find someone who is open to that. I don't know that I answered the question exactly, but if I could please, and I asked Kristen if I messaged you a minute ago, if I could add something on vitamin D. What I wanted to add to what Dr. Chan had said is we forget that vitamins are cofactors for enzymes. If we had to wait for chemical reactions in the body to occur, we could be waiting hundreds or even thousands of years for those reactions to occur. And so we need enzymes. And as it turns out, vitamin D is a very important coenzyme for the conversion of androgens, which are produced by the adrenal gland, into testosterone, estradiol, and progesterone. Testosterone, of course, predominantly in males, but in women as well. And so we wouldn't have the sex steroids at all if it weren't for the fact that vitamin D is so essential in converting, especially specifically, if those of you who are wanting to know specifically, the androgens that are coming from the adrenal gland have to be converted, and the testosterone and androgens in the corpus luteum, which is the bloody scar that's left after the egg is released, has to be converted into progesterone. And for that reaction to occur, that chemical reaction to occur, we need vitamin D. So I asked Dr. Chan long ago in one of the conferences where we met, and I said, maybe you're right. Maybe vitamin D is the key to all of this. It turns out he is right, that it is a very important cofactor. So bless his heart for spending, so much of his time looking at that. I'm in agreement. Most of us are vitamin D deficient. I'm in a practice now. I work every other week in Texas, where I have a partner who is Jewish and has not been exposed to any of this. And he's constantly amazed with what I have learned since I left residency training, simply because of the people that have been put in my path to be able to practice this way. But anyway, thank you very much.
Thank you, Dr. Martin. All right, we've got time for just one more question. And this one I'm actually going to direct at all of our panelists. And the question is, if there is one thing that you could tell a young girl about her period or her reproductive health, what would it be?
Well, I already put in the chat box that I would tell every young girl that ovulation is a sign of health. In order for you to ovulate, your hormones have to be in balance. And when you get your period, we call it your period because it actually marks the end of the ovulatory cycle. So view your period not as this, thing that you have to deal with or this negative thing, but it's a sign that your body is working the way it is designed to function. And when you can learn to track your menstrual period and you can learn to track your cervical fluid phase so you can begin to predict your period, and when you're ovulating, you will be truly empowered with the way your body is designed to function in a healthy way. So that's what I would say. Ovulation is a sign of health. Learn to chart your cycle and be empowered with that knowledge.
So perhaps here, I also wrote it down in the chat box. So I would say that body literacy empowers you to make good decisions for your life project, and you should embrace your fertility.
Dr. Chan or Dr. Martin, do either of you have one thing that you would say?
Gosh, I think people have said it much better than I could. So anyway.
Yeah, I think it has all been said already, and I agree that the best description is ovulation is a sign of health. And in fact, Professor Pilar Vigil has written a book with that very title, Ovulation is a Sign of Health. Thank you.
Wonderful. Thank you all so much. Well, we are coming to the end of our time. I want to thank you so much to all of our wonderful panelists for making time to be here in very different time zones. And thank you so much for accommodating us and being able to attend. Thank you to all of you who attended our session today from all over the world. We really appreciate you being here and for all of your wonderful attention. To my fellow team members for planning this event today, thank you as well. If you would like to reach out to the team for any more information about the work that we do or about the Billings ovulation method, I put over in the chat, you can visit wombinternational.org or you can email us at womb.un.team@gmail.com. We would love to hear from you. And we have what I'm calling the after party over on Zoom. If you guys want to stick around, if you'd like to talk with any of us about any other questions that you may have or get more information, please hop on over to that Zoom link, which was also placed in the chat. So thank you again, all of you who are involved today. We really appreciate all of you, and I hope that you all have a wonderful day.
See you at the after party.
Thank you. Bye-bye. Bye-bye.
Okay, so are we going to just stay here until they decide to stop us? Do we want to go ahead and end the meeting for all?
We could end the meeting for all. I just have a button that says leave, so I don't know if I can shut it off.
Okay, so what I can end the meeting for all. So I guess that would be